You guys have any questions from the test? There was one partial give back. I was due to a miskey. I forgot to star something on the test, and then they randomly selected an answer, and that ended up being the wrong answer. They had a 20% chance, and we failed. So if you pick the one that was incorrectly keyed, and you pick that, you did. You got credit for that, which was polymyxin was incorrectly keyed, so you got credit for that if you pick that. And then if you pick neomycin, which was the correct answer, then you also got points for that. If your grades are not reflecting that, then I would suggest reaching out to Leanne. I don't have access to ExamSoft, so I can't see what you picked to futz with any of that stuff, okay? Any other questions from the exam? So that's pretty much how I write my test. Most of the time you're just going to get 5 drug choices, and you have to be able to link those drug choices back to the mechanism of action, to the classes they fall into, adverse effects, etc. Because again, when we're learning it here and during the lecture, we're kind of starting from like the disease state down and learning what the pathophys is for the disease state, then learning what classes of drugs we can use to treat that, and then getting into the specific drugs on the test. So you have to do it the reverse way. You have to kind of start with the drugs and then link that back into the categories. And then from that, you know what the mechanism is, you know what the adverse effects are, things like that. That makes sense? So again, it's kind of like a reverse sort of process here. If you need help with that, come and talk to me. We can talk about tips and things like that to kind of help you through that process there. So it'll be pretty similar from here on out, just be the different topics we talk about. Okay? Very good. And that last bit of opto that we covered last week will be on this next test, FYI. All right, so our glaucoma stuff and those last couple meds we talked about will be on there. Okay? Getting into ENT, not so much on the dental side of things, but just getting into ENT. Talking about acute otitis media. Now, have you covered ENT anything in your medicine course? Good. So this should be a good review for you. We've already talked about a lot of the antibiotics, so this will not be any kind of new topics here. But it's good to know if you have a kid who comes in and they have a really angry looking tympanic membrane, see that fluid behind there, you're going to know how to treat that, right? What do you use? Moxicillin, right? That's a really good choice. What if they're allergic? Erythrin? So this is going to be the things to focus on for my class here, is like when we cover a specific disease state, it's good to know what the first line agents are and then have a backup in mind as well, right? So that way if they fail therapy, what can you use as a backup? If they are not going to tolerate the initial first line therapy, what's a good backup, okay? So those are good things to know for these purposes here, because again, when you're on rotations and your attending provider is like, okay, well, what do you want to do for this patient? And you're like, all right, I know this one's amoxicillin. And they're like, well, they can't get amoxicillin. And you're like, amoxicillin, that's all I got. You want to have a backup, right? So this is why we kind of go through this stuff. Yes, ma'am.
So if you gave us that question on the test, would you specify the reaction of the allergy? Because if it's just a rash, I remember saying you could use the stuff before. Anaphylactic type reaction, you wouldn't want to use the stuff. So is that?
So that's not quite true, right? I said if they have a true anaphylactic allergy to a penicillin, it's less than 1% chance they're going to have a reaction to a cephalosporin. Yeah, and I'll make that pretty clear. Like, I'm not going to give you like a really kind of, say they had a rash last time they received amoxicillin, which should they get? And then if I put amoxicillin as a choice or something, like I'm not trying to trick you on that kind of stuff. It'll be pretty obvious. Like if penicillin's contraindicated, it's going to be fairly obvious that is the case there, right? Or if they have a sulfa allergy, don't give them Bactrim, right? Things like that. Okay. Yeah, so I'm not here to trick you, even though you might think otherwise. I promise you that is not my intention when I write my test, okay? Anywho, so when you're looking at acute otitis media, you're going to see these 3 common bacteria come up here a lot as causative organisms. You're going to see this pop up a lot for a lot of the upper respiratory tract infections here, right? Now, again, certainly viruses are going to be playing a role for otitis media. However, frequently you're going to see sort of a super infection, right? They're kind of superimposed on one another. Frequently they'll get like a viral infection that will kind of cause some eustachian tube dysfunction that leads to the bacteria kind of sitting there and being able to proliferate. So those 3 bugs you end up trying to treat are going to be strep pneumo, H. influenza, and Moraxella catarrhalis. Those are 3 common ones you're going to see for most of the upper respiratory stuff that we're going to run into during this lecture here. Okay, does that jive with what you've learned in your medicine courses? Okay, good. If there's something different, make mention of it so that way we can talk about it. It could be just a perspective thing. It could be, I could be wrong. Who knows? Maybe your teachers are wrong. Who could say, right? Maybe we're both wrong. That has happened before. Anyway, just kidding. We're always right. So for otitis media, so points here to note is that yes, high dose amoxicillin is going to be our kind of go-to therapy. Now again, I'm not going to quiz you specifically on dosing for the testing purposes, right? If I include any doses, just assume they're correct, unless I'm asking you to calculate like fluids or something like we've done before, right? But that'll be very very specific. I'm not going to ask you, okay, well, which dose of amoxicillin is appropriate for this patient? Like, that's not going to be a test question. I'm not going to get that granular because you can look that stuff up, right? Our purpose is here to get you familiar with it so that if you see a kid who has otitis media, you know what drugs to go to look up in order to get those dosings there, okay? Now, we do a little bit higher doses because sometimes it can be difficult to kind of get high drug concentrations there in the inner ear, especially due to things like strep pneumo becoming more resistant over time. And so frequently, if they have maybe resistant disease or if it's very severe, then we'll bump them up to amoxicillin clavulanic acid, right? Now, what's the benefit of using clavulanic acid in conjunction with amoxicillin? The beta-lactamase inhibitor, right? So you're going to get broader coverage. It's going to be able to treat more of those resistant bugs. So potentially if you have a kid who comes in and they have frequent otitis media and you've given them amoxicillin a couple of times and this time it's not working, it's reasonable to bump it up to Augmentin, okay? Just because they failed amoxicillin does not mean they failed Augmentin, okay? Some people kind of have a false misconception about that. So that's a good thing to back up to. If they have a true allergy and they cannot receive amoxicillin, and what class was amoxicillin? What did that fall into? It's a penicillin, but more specifically, there's an aminopenicillin. As a backup, you could do something like Ceftonir, which is what category? What type of cephalosporin? Third generation cephalosporin, right? Falls in that same category as like Rocephin or ceftriaxone, right? Kind of remember to keep those together. This is a good oral agent, right? Because most of these patients are treated outpatient. Most of them require oral therapy. Azithromycin could also be used. However, you do start to see things like strep pneumo resistance to macrolides, and so that's not going to be a common go-to. Ceftonir is pretty good in most cases there. And sometimes we'll have kids who can't tolerate oral. You have patients who that may not be appropriate, and so maybe if they're coming in-house due to the severe disease or they can't tolerate oral, we may either use like intramuscular or IV ceftriaxone as an alternative. So that's something you could do potentially. We've had some kids that will come back, say like 3 days in a row to the ER to get doses of ceftriaxone because they couldn't tolerate oral, and that's just what we had to do. Now kind of switching gears a little bit and going into rhinosinusitis, you're going to typically find that the same pathogens are going to be most common here, these guys, but they tend to have a little bit broader scope of bacteria as well. So now you're going to see more like strep pyogenes, you're going to see more Staph aureus, and potentially things like gram-negative bacilli. And so because of that, this is why your antibiotic initial choice is going to change a little bit. One thing to note here is that frequently this is going to be something that people overprescribe antibiotics for because they start it too early. Someone comes in and their sinuses are just like super inflamed, they feel miserable. But if it's only been a couple of days, chances are it's what? It's a viral illness, right? So there's a couple of things you're going to be looking for to see like, hey, is this a patient who really needs antibiotics? And so some of those things are going to include if they have symptoms for greater than 10 days, which again sounds like an eternity if you're sick, but that's one of the things we look for. If they have sort of a resickening that occurs, maybe 5 to 6 days in, they tend to get a little bit worse during that second half of that. That more speaks to it being a bacterial illness. And so in those cases there, we'll go ahead and start antibiotic therapy. So for this one, notice we skip amoxicillin by itself because we do know that we have things like influenzas producing pretty strong beta-lactamases. We'll automatically go to Augmentin. Okay. So again, if I ask you initial first-line therapy for a patient with no contraindication for AOM, you would say amoxicillin. But if I say for bacterial rhinosinusitis, it's Augmentin, right? So that's a little bit of difference there in terms of initial therapy. Now, looking at this, bless you, if they have a penicillin allergy, it's a true allergy. A couple different things we could try here. Because we have a little bit broader coverage, this is why we're going to choose a little bit of different antibiotics here than we would for otitis media. So as an example, you could use something like cefixime plus clindamycin, right? What kind of coverage do you get from clindamycin? Gram-positive and anaerobes, absolutely right. So you start to get some more of that Staph aureus, some of that strep pyogenes, things like that. So that's some additional benefit. But clindamycin by itself, does it get much gram-negative coverage? No. So this is why you have to combine it with something like cefixime. And again, are more drugs always better? Generally no, right? So this is why using 2 drugs to cover the same infection can be, you know, a little bit more difficult because this is not something you're going to culture frequently, right? Otitis media you don't culture very frequently, so because of that, you're kind of going just with empiric therapy. As an alternative, you could just use something like a fluoroquinolone, like levofloxacin, and that has broad enough coverage to be used by itself. But again, this is where we saw a lot of overprescribing of levofloxacin. It's a nice once daily, easy dosing medication that gets overprescribed for sinusitis, and guess what? What happens? Resistance is a big problem with this one, so you start to lose efficacy of those drugs over time.
Question.
Yes.
Clindamycin is pretty good drug, right?
Clindamycin?
Pretty good coverage. What if people are allergic to that? What would your...
They're allergic to clindamycin? Doesn't come up too frequently. Maybe. Oh, okay, yeah. So, like I said, rare things happen all the time when you look at it on a long time scale, right? So,
Pretty bad allergy.
yeah. Okay. Yeah. So maybe potentially, I'd have to look at the guidelines to see if they have any specific recommendations. But maybe something like Bactrim could be a reasonable alternative. We just have to see. And again, that's why it's good to know initial therapy. But then if you get stumped like that, someone's like, "Oh, I have a clindamycin allergy," and you're like, "No, you don't." And they're like, "You know, I really do." And you're like, "Okay, well, let me go find a backup," right? They're not like, "Oh, I had diarrhea." I was like, "Well, that's not allergy." But if you have a legit allergy, then yeah, you look it up, right? And you'll find a backup agent to that for sure. Yeah. And hopefully, if you're looking at the patient's chart, you would have already seen that they have a clindamycin allergy. You would already have in your mind a backup agent to start it before you go into the room and be like, "You don't have that," and they're like, "No, it's true," right? Okay. So then switching gears again, going to acute pharyngitis. Now this is interesting because frequently a lot of people are just carriers for this beta hemolytic, group A beta hemolytic streptococcus. However, oftentimes we're not really worried about the eradication of the infection because it's, you know, a lot of people just have it and they have no real actual disease. What we're trying to do here is to try to prevent the suppurative complications of having this group A beta hemolytic strep. So this is a case where we're trying to prevent things like rheumatic fever and other complications of the disease here. So here we're going to typically find that in order to prevent overprescribing, we have what they call a rapid strep test. We're basically going to do a throat swab for the patient there, and if the test comes back positive, then you know it's group A beta hemolytic strep, and you go ahead and treat it right away. Okay. However, you tend to find that that can have a relatively high, not high, but a relatively somewhat common rate of false negatives, to where they may actually have that beta hemolytic strep, but you did not actually get it cultured out on the, or that rapid strep came back negative. So in those cases there, you always do a backup culture, and that way if you send the patient home without an antibiotic prescription, you still run that culture, and if it does come back positive, then you just call the patient up and you can call in a script for them. Okay, so that's frequently what you may do. Or potentially you can give them a script and say, hey, don't fill this unless I call you up, so that way maybe you can avoid them having to call them the script potentially. It just depends on how you want to practice that. For this one though, this is going to be where we're using amoxicillin as our go-to drug here. This one's interesting because normally you'd see amoxicillin being used like twice daily, because is it a time or a concentration dependent drug? The time dependent, right? So typically you want it above that MIC. Here we only have to give it once daily, so you give a little bit bigger dose once daily. That does provide decent enough coverage there. Use it for about 10 days or so. As an alternative though, maybe if they couldn't tolerate oral because they got pharyngitis, right, or the throat hurts, maybe they don't want to tolerate that, you could also use something like benzathine penicillin G, right? Anyone remember what was specific about that? What was unique? Is IM. Why is it IM? Yeah, it looks kind of milky, right? It comes in that oil base, and that's important because it's a long-acting medication. That's why it's Bicillin LA. So if I had a patient who could not tolerate oral meds for this, I can go ahead and give them a one-time IM shot of Bicillin, and then they're good to go, right? So has anyone tried to give oral medications to a child before? Is it easy? No. Most of the time you're going to end up wearing it. So imagine giving a drug for 10 days straight can be difficult, especially if they have a sore throat and they feel crummy, right? So in some cases, it's reasonable just to do a one-time IM dose. Now, however, what's the drawback of doing that in a little kid? It is traumatic, right? I remember having to get an IM shot of something when I was a little kid, and my mom had to really talk me down off the ledge. I was like, nope, I'll just stay sick. It's fine. I'll be sick. The giant needle? Nope. Don't want it. Anyway, so those are typically the kind of the first line things there. So again, if the question comes up on the test and a patient cannot tolerate oral, they don't have any allergies, Bicillin is going to be a really good alternative to that. Okay, it's just a one-time dose, which is beneficial. If they have an allergy, again, using something like cephalexin, which is what generation cephalosporin? First generation, right? So we really don't have to go super broad coverage here. Your clindamycin could be used potentially, azithro, any of those would be reasonable in those cases there. Okay. Okay, so those are oral systemic antibiotics used for the majority of those cases there. Obviously, there's a few parenteral ones like ceftriaxone or Bicillin. Here we're going to also see that you can use otic antibiotics, right? So what's the benefit of using drugs directly into the ear canal? Yeah, no systemic effects. Good. What else? Get really high concentrations, right? Just like we were talking about with the ophthalmic antibiotics, the same principles apply here as well. And remember, can you use otic medications in the eye? No. Can I use ophthalmic meds in the ear? 100%. Yeah, I can always do that. So when you're doing this, and again, this is going to be more typically for patients with otitis externa, things like that. You don't use it as frequently for otitis media. More often than not, we're going to go ahead and use systemic antibiotics for that. But maybe if they have like tubes placed, right? If they've had a myringotomy with tubes placement, then potentially that is another route you can use your otic antibiotics for like an otitis media. But anyway, most of the time we're going to include an anti-infective plus a glucocorticoid, right? What's the benefit of using a steroid? Yeah, because again, the ear is like really red and painful and inflamed, and using a steroid can help to prevent or help to decrease that and help to provide comfort for the patient. And then the antibiotic is going to be able to do its thing. Because again, normally, what do steroids do to wounds? Or what do they do to the risk for infection? They delay healing. What do they do for the risk of infection? Increases it. But remember, we get really high concentrations of the drug here, the actual anti-infective, so this is not as big of an issue, right? As you would see with, like, say, systemic steroids. So agents we have available here include things like ciprofloxacin, which is what type of drug? Fluoroquinolone, very good. You may see it combined with a drug called dexamethasone, which is what type of drug? Yeah, it's a steroid. We'll talk about that a little bit later. So that's a combo called Ciprodex that you can use in the ears. Other ones include things like neomycin, polymyxin B, and hydrocortisone. It's called cortisporin. What would I worry about with that combination product? Yeah, or you see hypersensitivity from that neomycin, right? The ear's all red and inflamed from an infection, and then you have this hypersensitivity on top of that. That's not going to be very good. So we use that very frequently. Typically, that's a little bit cheaper than you see for something like Ciprodex, actually quite a bit cheaper, and so that can be beneficial from a cost standpoint. Or potentially we can use something like ofloxacin by itself. Those are the most common ones you're going to run into. So, as I mentioned, otitis media externa, the common indications here. Just remember, neomycin is not going to be good for patients who have hypersensitivity to that. And then polymyxin B is not going to be recommended if a patient has a ruptured TM or if they have tubes in place. This is because polymyxin B tends, when it gets into that inner ear space, you're going to find that it can have ototoxicity. It can damage the hair cells in the cochlea, and that can lead to hearing loss, right? That may be permanent. So you don't want to do that to have tubes in place. And I mentioned ciprofloxacin, dexamethasone, Ciprodex tend to be very expensive, and so frequently what we'll end up doing as an alternative is we'll actually use ophthalmic ofloxacin and dexamethasone and just have them apply that in the ear. Now again, using a combo drug is beneficial from a compliance standpoint. However, sometimes you got to do what you got to do, because if they can't afford it, then they're obviously not going to pick it up. So this is why we can use two of the drugs separately and still get the same benefit there. Okay. Okay. So any questions on the antibiotic side of things? All right. Getting into the antifungals. So a couple of different agents we'll have available to us here. Now again, there's a lot of other more systemic antifungals, which we may talk about at a later time. But these are common ones you'll see used for more ENT sort of purposes here. So again, when I think of like ENT in terms of like fungal infections, I think of things like thrush, right? So like an oral candidiasis, can occur in the back of the throat. There's some other drugs that can actually induce that, which we'll talk about later on in the pulmonology section, which is coming up next. But anyway, the first drug we have here, it falls into this category they call the azoles, and this is called Ketoconazole. So you always know it's an azole if it has azole at the end of the drug name. And so this actually works, interesting enough, by inhibiting the fungal CYP450. And by inhibiting that, it actually prevents it from forming its cell wall, and that then causes very similar damage to what you would see with, like, say, a penicillin, right? It's a cell wall active sort of agent here. However, what do you think it does in terms of interactions for us? You can see CYP interactions, right? So that's something to consider there as well. Fluconazole is another common one we're going to run into a little bit later on. We'll probably talk about that like in the OB-GYN section next semester. But this is important to note, is that you can see CYP drug interactions due to the fact that that's how the drug works, right? Other effects you can see with ketoconazole, you want to worry about things like QT prolongation. Now, we talked about QT prolongation before, right? What other drugs can cause that? Fluoroquinolones, macrolides. Yeah, we're going to run into a lot of different drug classes that can do that. Keep that in the back of your mind, right? Because remember, individual drugs by themselves, probably not a problem, but when you mix things together. So if I had a patient on ketoconazole plus levofloxacin, that's where you can run into that issue there. Or if they just have a naturally prolonged QT just due to, that's the, they just have that congenital issue, right? That's the thing that some patients can have there. Other things to look out for, things like, liver function tests, potentially if they're going to be on it more long term. If it's short term use, generally not going to be a big problem for these patients here. So as I mentioned, watch out. It's a very strong CYP3A4 inhibitor, so you can see other drugs being affected by this. And just to give you an example of there's a lot more drugs than just this, but here's several of them that can be affected by ketoconazole. So things like, heart active medications like amlodipine, digoxin, etc., all can have pretty more pronounced effects when you have a CYP3A4 inhibitor on board like ketoconazole. Okay. Again, don't memorize this list. We'll talk about individual agents later on as we get to them. Okay, another good one is nystatin. This one is actually nice because it is not systemically absorbed, so you really limit a lot of those systemic side effects you can see with that. Very frequently, we'll have patients who may be at risk for candidal infections, and who might be at risk for a candidal infection? Maybe babies, immunosuppressed patients, right? Anyone whose immune system really isn't up to snuff. So we'll do this frequently in our patients who are receiving chemotherapy who are neutropenic, right? They can't fight off their own infections. And so we'll give them nystatin to either swish and spit or swish and swallow because they can go ahead and coat the back of the throat, get any candida that may be growing there. And then even if they swallow, it's not a big deal because it doesn't get systemically absorbed. No real side effects associated with that. So that's frequently done. You may also see it used as a powder. You may see it being used topically as a powder. You see it a lot in like diaper rash creams and things like that. So it's a pretty common antifungal agent you're going to run into there. And again, what do you think about systemic side effects with this drug? Shouldn't be many, right? Very good. Okay. Next up, we have some antivirals you're going to be running into. So most often you're going to be running into things like herpes simplex, right? We have type 1 and type 2. Typically type 1 is found where? Yeah, usually on the head up, and then usually type 2 is found where? Usually more in the genitals. Now, can it be mixed up?
Yes.
Of course, right? So they can show up anywhere. Fortunately, the drugs kind of work the same regardless of the type of herpes simplex that it is, so you don't have to really worry about that so much. But certainly varicella zoster is a big thing you're going to run into. And then occasionally you can run into things like cytomegalovirus, which can cause really severe systemic infections if you have things like immunocompromised individuals. So that's one you're going to run into less commonly, but certainly you have a lot of patients with coming in with shingles, you have a lot of patients with herpes simplex, so it's just a very common thing you're going to run into. So when I say the antivirals are going to be guanine analogs, what do you think that means? They mimic the structure of guanine, right? And where do you find a lot of guanine? DNA, good. So what actually happens with these agents is that they are guanine analogs, meaning they get actually incorporated into viral DNA. However, they lack the sugar backbone, right? Remember deoxyribonucleic acid? You have that sugar backbone that's going to be forming the strands there. If you lack that sugar backbone, guess what? You incorporate that guanine into the DNA, you can't add anything onto it, right? So what do you think it does to the reproduction of that DNA? Stops it completely, right? So we call that a chain terminator. That is something we're going to be seeing frequently when we get to the oncology section. We have several drugs that do this to our cells, just like these drugs are going to do this to the viruses, right? So anyway, so it stops the replication of the DNA, and that eventually leads to viral death. Here are two examples of common ones you're going to run into. We have Acyclovir and Valacyclovir. What do you think the relationship between these two is? One has a vowel on it. That's true. No, we'll look at it. Yeah, we'll look at the difference here. So actually, Valacyclovir is a prodrug of Acyclovir. Okay. Why do you think we do that? So it won't bypass first pass, but it will help to mitigate the effect here, right? So we'll look at the bioavailability of these two drugs in a moment. But you tend to see that Valacyclovir as an oral agent has much better bioavailability than Acyclovir. However, if I were to give one of these agents IV, does it matter if I give it as a prodrug? Not really, right? Because what am I skipping entirely? First pass, right? So in those cases, there, Acyclovir is a common IV agent being used there. Valacyclovir and Acyclovir are both used orally. However, Valacyclovir tends to have better bioavailability in those cases there, right? I don't know if any of you guys remember when like the original commercials were coming out for Valtrex. This is a long time. I was a little kid when I remember seeing them come out, and they're just like, even if you have herpes, you can live a full life. And like, you see people like kayaking and doing all kinds of fun stuff. And I have no idea what it had to actually do with having herpes, but it is what it is. But again, it's important to know a couple of things about these because viruses tend to be treated a little differently than you're going to see with bacteria. Because with the bacterial infection, your goal is to get rid of it completely, right? With the herpes, are you going to be able to get rid of it? Nah, it's going to be there forever. So the point is we're going to try to mitigate how severe the symptoms are, to hopefully prevent some of the recurrences of outbreaks, and then hopefully prevent what else? Spreading it to your friends, right? You don't want to do that. So anyway, so looking at acyclovir, valacyclovir, this can be used both for herpes simplex, for varicella zoster, and again, they're going to be getting incorporated into that viral DNA and preventing further elongation of that chain there. And again, look at the bioavailability between these two. So what do you think it differs? What do you think? How would the dose compare between the two there? I have to give more acyclovir to get the same systemic amount than I would of the valacyclovir. That's kind of the benefit of that. Maybe less frequent dosing, less total dose you're going to have to administer because you don't have to pay that liver tax, right, when you give just pure acyclovir. So a lot of side effects seen with these medications here. So you see a lot of certainly nausea, vomiting, etc. However, you want to make sure patients are staying well hydrated, and that's because these drugs themselves, they can actually precipitate out in the renal tubules, so that they're not that the filtrate in the kidneys is too concentrated. The drug tends to precipitate out, which can lead to crystalluria. You can actually see the crystals forming in the urine. It can also lead to interstitial damage, which can lead to kidney injury. So you don't want to see that. Also, imagine, it's nice that these drugs are pretty selective for the viruses. However, they can somewhat affect our cells, right? And so you tend to see rapidly dividing cells getting affected, and that's where you can see bone marrow suppression, right? So potentially you can see maybe the white cells being suppressed a little bit because we're constantly producing new blood cells, and that can be affected by this as well. Again, it's pretty selective for the viruses, but you may see a little bit of bleed over effect there. And typically what you're going to find is you want to give, anytime you have a viral illness, start early, because that's the best way in order to shorten the duration of symptoms here, okay? So in this case here, you want to give it at least within the first 24 hours of symptom onset, because chances are they've had the virus, kind of reproducing and shedding well before symptoms start up. However, once the symptoms are there, then we can try and treat the patient, and that'll help with that out, okay? Yeah, so if you have like a shingles flare-up, you will frequently give acyclovir or valacyclovir for that as well. Yeah. So again, it's a pretty common occurrence. I don't know what other fact I was going to leap off onto there. I lost my train of thought. But yes, you would use this for shingles. Okay. We'll talk more about that later when we actually get into talking about more sexually transmitted diseases at a later section, so kind of keep that in the back of your mind. But those are common ones you're going to see used for things like herpetic stomatitis, things like that. We'll use acyclovir for that pretty frequently. Okay, any questions on those? I know we're going through it pretty quick. We have a lot of material to cover though. I'm dreadfully behind because of the testing schedules and whatnot. So it is what it is. We're just going to keep trucking through. All right, so ENT, anti-inflammatory. What do you think are some common anti-inflammatory drugs we can use for ENT stuff? NSAIDs and steroids. Yep, those are going to be two big ones, right? We're also going to lump in another agent here we frequently use. It's not really an anti-inflammatory, but it's going to have some other additional properties that we like for it, and that's going to be acetaminophen. So we're going to talk about that here as well. So the first one we have is going to be our salicylates, or aspirin. Have we talked about aspirin much before? I don't think we've covered that yet. So aspirin, or acetylsalicylic acid. Anyone know how you abbreviate aspirin? ASA, this is where the name comes from. So if you see acetylsalicylic acid, that's that ASA you're seeing there, right? Anyway, very frequently, normally what do you see it used for? As a blood thinner, right? As a cardioprotection because it's a platelet inhibitor, right? Yes. So use it as an antiplatelet agent there. And so we like that because it actually is an irreversible inhibitor of those platelets. So as soon as you produce a new platelet, aspirin will bind to that. It will prevent it from activating, and then it's kind of good for the life of that platelet there. Anyone know how long platelets last? Like 7 to 10 days or so. Yeah, usually how long that lasts. Anyway, but the way they're going to be working as an anti-inflammatory is they're going to be inhibiting the enzyme cyclooxygenase, right? COX is how that's normally going to be abbreviated. And so we have two different enzymes of that, COX-1 and COX-2. That'll become more important, and then we talk about GI stuff later on. But just know that this is going to be a non-selective inhibitor of the COX enzyme, okay? And actually, this is going to be the same exact effects you're going to see with the NSAIDs, right? So the same mechanism of action here. Now, normally when you start with really kind of low doses, the main thing you're going to find are going to be the antiplatelet effects. And of course, the main side effect you would see with antiplatelet effects is what? Bleeding being a risk, certainly. When you get to higher doses, things like maybe 650 milligrams a gram, this is where you're going to see more of the antipyretic effects, which means what? Good for fever, it'll reduce fever, and then also the analgesic effects, right? Meaning it's good for pain, right? So it's going to be anti-inflammatory, analgesic, antipyretic. Once you get to even higher doses, that's where you get more of a strong anti-inflammatory effect. This is where you're going to see this used more for things like rheumatoid arthritis and whatnot. Notice here at higher doses you can start to see tinnitus start to develop. So that's something also, if you ever hear like a patient complain like muffled hearing, that is something you can normally see with aspirin, either in high doses or some people are just really sensitive to that at even normal therapeutic doses. I remember I had one time a patient who had overdosed on aspirin, who was calling up the poison center because they were, they had taken a whole ton of aspirin. They were really worried and they wanted to know what to do. And so I was on the phone with them and I was like, okay, well, how much did you take? And they go, what? How much aspirin did you take? What? Because they had really bad tinnitus. They couldn't hear what I was saying. And I was like, oh, exactly what the drug. I'm going to call 911. They came and they saved her, right? Anyway, note here that aspirin can be really nasty in overdose, and so I'm not going to get into that here, but just know that really high doses can be a very, very dangerous drug. I've had one patient who every time he had chest pain, he was told every time he had chest pain, just go ahead and take an aspirin. And so he'd have like several times a day, and so he's constantly taking aspirin throughout the day. And then there's one time where he called 911 because the chest pain wasn't going away. And so EMS got in and they said, have you taken any aspirin today? And he didn't really understand what they were asking about, because normally he's taking like a BC powder, which is aspirin. And he was like, no, I haven't taken any aspirin today. And so they gave him aspirin, and then the resident gave him aspirin. He actually got into the ER, so they ended up having to treat him for an MI plus aspirin toxicity. So be careful with that drug. But anyway, for our purposes here, we're going to be using it mainly for the antipyretic and analgesic sort of properties here. So remember that you want to be careful using this for patients with, say, a bleeding disorder. We typically don't use this very frequently for pregnancy. However, there may be some uses for pregnancy-related hypertension or preeclampsia. Don't worry so much about that. Also note here that if a patient has a history of peptic ulcer disease, aspirins and other NSAIDs, they actually degrade the protective barrier that our stomachs produce to keep our stomachs from basically digesting themselves, and so you end up losing that. So that's just something you want to be aware of. This is why frequently NSAIDs and aspirin are a cause for peptic ulcers. Again, we'll talk more about that later in the GI section, but just keep that in the back of your mind. Another thing to note here as well is that very frequently when you have a viral illness, you get feverish, you're going to be receiving medications for that. It's really important for little kids, or really anyone, say less than 16 or so, if they have a viral illness, do not give them aspirin, because there is a chance you can induce what they call Reye syndrome. And so this is a very unique thing to aspirin, is this instance of Reye syndrome. Basically, it's this fatty liver encephalopathy that can develop here, and early signs of Reye syndrome actually look a lot like a viral illness, right? So they're kind of lethargic, and they're nausea, vomiting, and they're febrile, and it's just they feel kind of miserable. That could also be early Reye syndrome, right? And so mortality can be really high if you don't notice it, and if you just say, well, my kid just looks really ill, but they're sick, right? They have a virus, whatever, and they don't necessarily get to the hospital quick enough to manage this. Later on, this is where you start to see more progressive encephalopathy. You can see hypoglycemia, liver damage occurring here. So it can be pretty nasty. So because of that, they have influenza, chickenpox, anything like that. Just don't give them any aspirin. Now, it's not to say that no kids can receive aspirin, because certainly we do this. For instance, in our cardiac unit over at Nemours, we have little kids that have to be on aspirin for the antiplatelet effects. Or if you have Kawasaki's disease, this is where kids will get aspirin in order to treat that. It's one of the drugs of choice. So it's not completely contraindicated, but they have a viral illness. This is not where you want to be using aspirin. You can kind of see the stages here. And again, early on, it can look like a viral illness, and then it just gets more and more progressive to the point where they may potentially succumb to that. Yes, ma'am. I want you to know, say for instance, I said a child was diagnosed with the flu in the ER. The mom had been giving aspirin for fever, and then they present with vomiting, high fever, lethargy. You'd be able to recognize that sort of thing there, right? I don't know that I would say which stage is this patient in. They came in with fixed dilated pupils and coma. I'm not going to get that specific with it, but you should be able to recognize that, or to know who aspirin might be contraindicated in, right? Yes, ma'am.
So it won't happen in adults usually, or can you see it?
As far as I know, it's not really something you would see with adults. So that's why I say anything less than 16, you typically avoid it. I've not delved too deep into the research to see why that is. I just know that just don't use it. And
Okay.
It's good enough for me, right?
So if an adult overdose is pretty bad, what would you say?
If an adult overdoses on it, it's a lot more of a mixed acid base sort of issue. I can probably talk an hour about aspirin overdose, but I don't want to bore you completely to death or to induce any aspirin overdoses as a result of that. You're like, I can't handle this anymore. Just just take the whole bottle. No. Yeah, I was looking at that and I was like, oh yeah, you see all kinds of mixed respiratory metabolic acidoses and alkaloses and all kinds of things there. But anywho, yeah. Also note here I have Pepto-Bismol. Anyone know why that is? You know what Pepto-Bismol is, the generic name? Bismuth subsalicylate. Salicylate is the key term there, right? So it indicates it's still in the same family as aspirin. So, and again, a lot of kids have viral illnesses. They're nausea, vomiting, diarrhea. Frequently give them Pepto-Bismol, right? Avoid that. You don't want to do that. Does anyone know how you can tell if someone's been taking Pepto-Bismol if they come and say to the ER? Is it what? Okay, yeah, so you can see some discoloration. That's one thing. What if you did like a KUB on them, like an abdominal X-ray? The bismuth actually will show up. So if you see these like little punctate marks kind of throughout the GI tract, that can actually be signs that Pepto-Bismol has been ingested recently. So if you ever see that, that's usually what that is. Because bismuth is a metal, it's radio opaque, so it shows up on the X-ray. So and also it can like turn your stools black and whatnot.
Doesn't it turn your tongue black too?
Potentially. I don't know if I've seen that quite as often, but certainly the stools can turn black. Anywho, all right, so aspirin, you know, pretty good antipyretic, pretty good analgesic, good anti-inflammatory. NSAIDs get used more frequently, and again, this would be something that would be safe in little kids because it does not carry the same risk for Reye syndrome as aspirin does. Most frequently, ibuprofen or Motrin is going to be used. Again, it's over the counter. People use it very frequently to self-medicate themselves. Again, the same mechanism as aspirin, so it's going to. The only difference is this is a reversible inhibitor of COX-1 and 2. That only just means that it's not very good as an antiplatelet drug. So when we talk about cardio stuff, that'll become more important there. But for these purposes here, again, it's going to be a reversible inhibitor, good for mild to moderate pain, good for fever, good for inflammation. This is used a lot for things like rheumatoid arthritis and other autoimmune diseases. So very common drug. You should definitely know this medication because you're going to have a lot of patients you're going to either give it to or are already going to be taking this here. Okay. Note the doses are going to differ depending if they're getting more outpatient sort of. If they're getting over-the-counter doses, typically you get like 200, 400 milligrams. Inpatients where you're going to be prescribing higher doses, potentially like 600, 800 milligrams. Note here that, again, be careful in using this in patients who have a history of, say, peptic ulcers, especially if they were NSAID induced previously. You'll also find, and we'll talk more about this when we get into the cardiac section here as well, but Motrin and other NSAIDs typically blunt the antihypertensive effects of your medications used to treat hypertension. They can also induce acute renal failure. Just know that it causes it now. We'll talk about that mechanism later when we get into actually talking about the kidneys and whatnot. So just keep that in the back of your mind. Be careful using this in patients with kidney disease. Also patients with like CHF, you can see more fluid retention, edema that can develop with that, okay? And again, you can see there's a ton of interactions with this, and this is why it's so important when you do your medication histories, you have to ask what? What do you take over the counter, right? What do you take that you can get without a prescription? You have to ask those questions because they could be self-medicating with Motrin and you not even realize it, right? It's because it may not show up on their medication list. So ask them how often they're taking it, how much they're taking, etc. Because you can see it can affect things like your antihypertensives, like your ACE inhibitors. It can affect things like causing renal failure in patients who have kidney disease. It can cause different levels of things like lithium and methotrexate. Again, the individual examples are not so important to know for this exact instance, but it's important to know there's a lot of drug interactions, so you want to be aware of that, okay? Anyway, also imagine it has some antiplatelet effects, at least while it's around, while it's still in the system. And so if you had a patient who's also taking something like warfarin or another blood thinner, this is where you can also see synergistic actions there. You can see increased risk for bleeding, okay? In terms of contraindications, obviously they have a specific allergy to the product that would be contraindication. Some patients may actually have their asthma exacerbated by NSAIDs, so those patients you want to be wary of as well. If you ever hear someone having an aspirin or ibuprofen allergy and it said they caused an asthma attack, that's what that is, and so you want to be aware of avoiding that for those patients there, okay? Those are the big things to think about in terms of Motrin though, okay? But good as an antipyretic, good as an anti-inflammatory. Now, acetaminophen, or Tylenol itself, is not an anti-inflammatory, right? This has a different mechanism than your NSAIDs will, but I kind of lump it together here, mainly because you're going to see this used so frequently in terms of self-medication out on the over-the-counter side of things. You're going to see this being used quite frequently in conjunction with NSAIDs to manage things like fever and pain. So here we have Tylenol. Has anyone ever was curious where the name Tylenol actually comes from? It actually has to do with the chemical name of the drug itself. And again, this is something you can use to wow your family members or friends, right? So if you ever look at the name Tylenol, that's where the brand name comes from. So again, You become the life of the party anywhere you go if you can show them facts like this. Sometimes this gets abbreviated. Anyone know what the abbreviation for acetaminophen is? There's the APAP. That's what that APAP is, typically the abbreviation for acetaminophen. That actually comes from this name as well, acetyl P-aminophenol. Sometimes it gets rearranged a little bit in the chemical name. So that's where that name APAP actually comes from. Okay. Anywho, so looking at this, you're going to see that it's good as an analgesic, good as an antipyretic. It is not an anti-inflammatory. Okay. We don't really know the full mechanism for why Tylenol works, but we just know that it works kind of more centrally in the CNS to actually decrease pain and fever, but it does not do anything for inflammation. So if you stub your toe and you have a big inflamed toe, this is not going to be as good for that. It'll help with the pain centrally, but it doesn't really do anything at the actual site of action like an NSAID might. Okay, so something to note there. Again, frequently you're going to note that dosing is really important for this one. Typically, you do not want to go over 4 grams in a day for an adult. Otherwise, what organ toxicity can you see? Liver. You always want to think Tylenol or acetaminophen. You think liver toxicity. Okay. Now keep in mind that for some patients, especially those with pre-existing liver disease, you want to go even lower than that. Some patients don't want to go more than 3 grams. Some patients you may just want to avoid it altogether. Okay. Again, how would you know if a patient's having a liver injury due to acetaminophen? That's pretty severe. Like, that'd be pretty late presenting. So if you saw them jaundice, you'd be like, oh boy, this is bad, right? What would you see before that? Any lab tests you could do? LFTs, what did you see bump there? Would they be increased? Which ones would be increased? AST and ALT typically are going to be increased there, right? Those are your liver enzymes that are releasing because those cells are dying off. They get released into the bloodstream, right? Those are signs that your liver function is not going to be doing quite so well, okay? So just things to note with that. I actually had a student who was on rotations, and they came back, and when they do their EOR, they present their patient case they had there. And actually had a patient who had mono, and they had increased LFTs as a result of that. So they said, you know, they were treating the patient in-house for a couple of days, and they said, okay, we're going to go and use Tylenol for fever. And I was like, it's interesting you want to use Tylenol for fever because their LFTs already bumped, already in the several hundreds. You know, what else could you use, right? And in that case, what could you use for fever? Use an NSAID, right? So if Tylenol is not going to be a good option because their LFTs are already bumped, use something like an NSAID, okay? Again, we did not really see the same sort of hepatic toxicity with NSAIDs as we do with Tylenol, okay? For NSAIDs, though, you worry more about the renal side of things, so just something to kind of keep in the back of your mind. Again, if you have patients who are like chronic alcoholics or they're chronically drinking and they have liver injury already, again, this can increase that risk when you put Tylenol on top of that, right? And again, this is a very frequent drug that I see patients overdose on. What do you think that is? It's cheap, it's available. I can go to Costco and get like a 55-gallon drum of this stuff for like $10, right? Also, you see it frequently in combination with other medications. Acetaminophen and hydrocodone, acetaminophen and oxycodone, right? So because you see it very frequently co-formulated with opioids, because it is a good analgesic, it gets that synergy there. You frequently see patients who are overdosing on opioids will frequently have a Tylenol overdose on top of that, right? So that's something to think about. It's very ubiquitous, right? You find Tylenol everywhere you go. Okay, any questions so far? Okay, so let's do the antihistamines real quick. So what do you think these drugs are going to do? Block histamine, yeah, absolutely. So histamine, normally what does it do in the body when we see histamine being released? You think allergic reactions, right? So again, you think about like redness, wheal, flare reactions, right? When you're exposed to an allergen, a lot of that is due to histamine. There's other mediators as well, but we're going to mainly focus on the actions of histamine here. And so typically when you find allergies are occurring, you get a lot of vasodilation. It causes a lot of edema, causes swelling, causes redness. Also, histamine tends to sensitize those little nerve fibers that cause itching and things like that, so I get really itchy when you have allergies occurring. Part of that is due to histamine. And so we have several medications that are going to be useful to help kind of blunt that effect there and kind of reverse some of these issues. Again, just to look here, you can see that the 2 main types of receptors you have are going to be H1 and H2. H2 is going to be something you're going to see more to do with GI effects. We're going to focus on that one later. The thing I want to focus on today is going to be H1 receptors, okay? It's going to be important in terms of things like let's see here. It's going to be more important in terms of things like bronchiolar smooth muscle, in terms of things like GI smooth muscle, things like that. Those are going to be the things I want to focus on for our purposes here, because that's what you normally think about in terms of like allergies, right? Either seasonal or say due to a certain exposure, due to anaphylaxis, anything like that. These drugs are going to have the same activity. Again, just talking about the different activities here, notice here you're going to see more mucus secretion, right? So when you have someone who's having allergies, how do they normally present? Let's say seasonal allergies. Nose is running, eyes are running, right? They usually have a lot of secretions. Frequently, when you give an antihistamine, what do you think happens? They dry out, right? So you're going to see that there's a lot of drying effects with a lot of these antihistamines to counteract these issues here, right? You're going to see a lot of swelling and edema due to those vessels being dilated. That's where you get a lot of that, runny nose and things like that coming about from that. Also, bronchoconstriction can be a big issue because what can that lead to? Trouble breathing, right? They're not going to be able to exchange air very well. So, like patients who are asthmatics that have an allergic reaction to something, that bronchial smooth muscle constriction can really impede airflow, and it can cause an asthma exacerbation. We'll talk more about asthma a little bit later on. But again, you're seeing the same activities here. We'll focus more on H2 receptors later on because mainly these are going to be important for causing gastric acid secretion, which can lead to what? If you have too much, yes, it can lead to ulcers, it can lead to GERD, it can lead to all kinds of things. We'll focus more on this on the GI section probably next semester, I think. I'm not sure. Whenever we get to it, we'll talk about H2 receptors, though. Okay. So when we use an H1 antagonist, we're going to see these peripheral effects occur. We're also going to see there's going to be some central effects as well. Okay. So it's important to delineate between these two because we're going to have some drugs that only work centrally, or work centrally and peripherally, or only some drugs that just work peripherally. Okay, I'll talk about the delineation in just a few minutes here. But normally, when you have the peripheral actions of an H1 antagonist, right? When I say antihistamine in this case, it's H1 specifically. You're going to see that it's going to block that smooth muscle contraction, so it can block effects in the GI tract, the bronchial smooth muscle. It can affect that vasodilation, so you'll see constriction of those vessels. You're going to see decreased secretion, edema, itching, all that sort of stuff is going to be reversed by blocking that histamine. Right? We've kind of already talked about antihistamines a little bit before. Where do we cover those? Talked about them in terms of the eyes, right? We're talking about in the ophthalmology section. So we're seeing the same activity here. It's just seeing this more on a systemic sort of basis. Okay, so the CNS effects are going to be really important as well because this causes a lot of the side effects, or in some cases, the actual therapeutic effects of these drugs here. So you're going to find that the majority of the H1 antagonists we have are going to cause sedation as a side effect. And it's because most of these drugs don't just inhibit histamine, but they also inhibit some other receptors as well, as we're going to see here. You tend to find they're pretty additive when you combine them with other CNS depressants, right? So if you had a patient who's on, say, a benzodiazepine, for, say, anxiety, this can have synergistic effects. If they were taking alcohol, which is a CNS depressant, you're going to see some pretty synergistic activity here. Now, that can be a good thing, though, because we actually use this for induction of sleep for some patients. So if you have someone who had insomnia and you wanted to use something kind of a low-grade sedative, this is something they can buy over the counter, right? So Unisom is an antihistamine, technically. Doxylamine is the generic name. What's interesting, though, is that for most people, they get a little sleepy when they take a Benadryl or something like that. However, some patients can have what they call a paradoxical reaction, where they actually get super wired, they're bouncing off the walls, they're really agitated. I see this more in children. So when you give them Benadryl, you'd expect them to go to sleep. Instead, they just go crazy, right? So that can sometimes be a big problem, especially if you don't know how kids are going to react before you give it to them. Typically, though, when you use a second-generation antihistamine, I'll show you the list of these in a moment, they get much less sedation. And the reason for that is because they don't cross into the blood-brain barrier, into the CNS, and so they can't really work on the brain to cause that sedation. Okay. Some other effects you're going to see, and this is more from that CNS effects, is the fact that they can work as antimuscarinics, right? Now, muscarinic receptors are normally hit by what? We talked about this briefly because we talked about cholinergic agonists in the ophthalmology section, acetylcholine, right? So we're talking about muscarinic receptors being affected by acetylcholine. These will actually block that. They'll block those muscarinic receptors. And you guys remember the mnemonic we used to talk about that? Did we talk about the mnemonic for antimuscarinic? We'll talk about that today, don't you worry. I'll talk about the different actions there, but it's a really important mnemonic to remember to know what happens when you block those acetylcholine receptors. But the other big thing is also an antiemetic action, okay, which is good. So if you have a patient who's like going on a cruise and using an antihistamine like this may be like a really good option for them because it will help to decrease some of those vestibular disturbances that occur when you have patients who are on the cruise ship and they're kind of floating around and their cochlea don't really know what to do with all that motion, and then that causes nausea. This can help to blunt some of that. So you can have antiemetic activity not just on those muscarinic receptors, but they also work directly on the CTZ. Anyone know what that means? It's a chemoreceptor trigger zone. It's a specific part of the brain that when activated causes emesis, and so it can actually help to block that. And just to give you an example, for instance, promethazine or Phenergan is actually got the strongest antimuscarinic actions and is kind of the best when used for things like motion sickness. So has anyone ever heard of Phenergan before? Yeah, I remember one time when I was like, it was before pharmacy school, but I was like really sick and I was just like really snotty and just felt miserable. And my aunt was like, "Here, take one of these Finnegan." And I said, "Okay," because my aunt handed me a drug. I said, "Let's take it," right? It was prescribed to her, but not to me. That was illegal. Should not have done that. Anywho, so I went in and took the Finnegan, and this thing just knocked me out. I was out for at least like 12 hours, I think. I was so just like sick and just tired, and it just knocked me out. And then when I woke up, I was so dried out afterwards. I think everything was all crusted over, and I was just like, I can't even open my eyes practically because everything is just dry. But it goes to show you like just how strong these medications are when they're blocking those muscarinic receptors. But anyway, so again, we're going to see these very good activities here. It's going to dry the patients out typically, especially the ones that are getting into the brain and working there. So where do we use these? Typically for allergic reactions. We're going to see them used for things like motion sickness, for sleep induction, and then we're going to see they're also really useful for anaphylaxis, and we'll talk more about that later in the pulmonology section. However, the adverse effects, what are you going to see? Sedation is going to be a big one, and this is mainly going to be for the agents that actually get into the brain and work there. So again, when you take a Benadryl for an allergic reaction, say for instance, if you have to go to your pharm class but your seasonal allergies are kicking up, is that a good time to be sleepy? No, you're like, I'm already going to be sleepy anyway, sitting there for 2 hours. I can't handle any other drug-induced sleepiness. That can be a problem. However, if you want to go to sleep and you're miserable and you're having allergies, that's going to be a beneficial effect, right? So that's going to be something that is either a therapeutic effect or a side effect, depending on the case there. Now, the antimuscarinic activity, right? Here's the mnemonic to know, to remember what antimuscarinic effects, what blocking those muscarinic receptors typically cause, right? So it's pretty easy to remember. So they get dry as a bone, because they're going to dry out and decrease secretions, right? They can also cause things like urinary retention. It slows down the GI tract, right? Because again, you're blocking that parasympathetic nervous system. So you get dry as a bone. Anyone know the rest of this one? Never heard of this one? That's a good one, right? So they get dry as a bone. They get red as a beet. You can actually see some vasodilation. So they get kind of red, and beets are red, right? Unless you're colorblind. I don't know what the color they are. They get hot as a match, or hot as Hades, some people say. So oftentimes you'll see hyperthermia develop because of that, right? So you get a little hot. They are going to be blind as a bat. Anyone know why that is? Remember we talked about this in the ophthalmology section, right? What happens if I give tropicamide or I give atropine in the eye? People, constriction or dilation? Dilation. Their pupils will dilate. What happens to that accommodation of the lens? They can't do it. Remember, you ever had your eyes dilated and you can't see for the rest of the day practically? That's usually due to an antimuscarinic, right? Something like a tropicamide. So you get blind as a bat. They're going to be mad as a hatter. So this is where you can see that sedation, or like I mentioned, those paradoxical reactions. You can see some people get kind of wired and kind of anxious, or sometimes aggressive. This can lead all the way to things like hallucinations, seizures potentially. So mad as a hatter. Anyone know where that term mad as a hatter really comes from? Also Wonderland. What's the historical context for that? Yeah, so it's actually felters, or people who were making hats. They were actually using a lot of liquid mercury to do that process, and so they're actually eating mercury toxicity. So anyway, again, another fact you can go and wow your friends, and you go out for a Friday dinner with your buddies or whatever, like, hey, listen to this one. Tylenol, you ever wonder why it was APAP? This is why. No, I'm just kidding. But anyway, so that matters a hatter. So those are the 5 big things you think about. Also, you're going to see tachycardia, right? It's also going to cause the heart to speed up because you're blocking those muscarinic receptors in the heart. Okay, those are the big things you're going to see with antimuscarinics. And this is what you can see if someone's taking Benadryl, or someone's taking doxylamine or Phenergan or anything like that. Okay, I'll get to the specific drugs in just a moment here. Okay, so these are the drugs you're going to run into. So notice the delineation between the first and second generation. I'm mainly going to focus on these 2. There's also an intranasal antihistamine. What do you think about the side effects of an intranasal formulation versus, say, a systemic one? Less or more? Much less. So much less side effects. Also, it's not going to see a lot of systemic activity with that. So anyway, so the first generation ones, you're going to notice some of these are going to be in a lot of over-the-counter preparations. These are pretty old drugs. So for instance, like chlorpheniramine is very frequently found in a lot of cough and cold products sold over the counter. So if you ever see like Coricetin cough and cold, frequently has chlorpheniramine in it. NyQuil frequently has chlorpheniramine as an antihistamine in it. And again, NyQuil, what's it going to do to you? Makes you sleepy, right? And that makes sense because one, it has a little bit of alcohol in it, and then two, it has chlorpheniramine, which is going to be sedating. Makes sense. Dimenhydrinate, which is Dramamine. You have things like diphenhydramine, which is Benadryl. Benadryl is really great because we have IV formulations of that as well. So if you go into the ER, the urgent care of the hospital, you very frequently you may get IV Benadryl for severe allergies. We also have things like hydroxyzine. We have meclizine and then promethazine. These are all going to be really good, strong anti-muscarinic activity, antihistaminic activity, and so this is going to be important when you're looking at their side effect profile. Okay, these are able to cross the blood-brain barrier and interact with the CNS, which is why when you're looking over here, and again for my charting purposes, or for this chart's purpose, for memorization on the test, do I want you to know if it says medium or high or low? Not for individual agents, but I want you to notice the trends here. So for the majority of these first-generation agents, what do you notice about the side effects? Most of them are medium to high. And that makes sense because they're actually getting into the brain and directly affecting things like the chemoreceptor trigger zone, the muscarinic receptors, etc. So you're going to see a lot of those effects here. The second-generation agents actually do not cause many of those side effects. What do you notice about the second-generation ones? Very low to none, right? So very low activity there because they can't cross the blood-brain barrier. Basically, they're structured such that they have a permanent positive charge on them, and so they can't cross over, right? What do we say about positive charges on drugs crossing membranes? Can't do it, right? So they can't cross the blood-brain barrier, and thus they don't cause a lot of the sedating sort of effects there. So the three that we have in this category include cetirizine, which is Zyrtec, fexofenadine, which is Allegra, and then loratadine, which is Claritin, right? Now these are all over the counter now, which is great because you have good access to them. But before they were all prescription, and you had to use like Benadryl, right? And that was really kind of crummy because if I had to go drive somewhere and I don't want to knock myself out with the Benadryl, I was kind of stuck with dealing with those allergies. But now we have pretty good access to the second generation agents, and you really don't find any of that sedation. Now again, if you're having severe allergies, what do you think is going to be better to treat those symptoms? First generation or second generation? The first are definitely going to get more bang for your buck, but it's also going to have that additional sedating sort of side effects. Do you think things like fexofenadine or loratadine are going to be good for anti-nausea effects? No, because they're not getting up into the brain to actually affect that chemoreceptor trigger zone or the cochlea and things like that. So because of those effects, again, you don't use these as antiemetics, but certainly the first generation could be. Okay, so again, something to delineate there in terms of their activities and sort of the indications you might use them for. Okay. Xelacin mentions a nasal antihistamine. Again, you're going to find that it causes much more local sort of effects here. You're not really going to see much of the systemic activity, which can be useful if you're really just having that kind of rhinitis with that. Note here as well that you can see as side effects commonly things like bitter taste. What do you think that is? Again, you get a drain down the back of the throat, so that's one thing to know. And then also epistaxis can also occur here as well. So be aware of that, and that makes sense because blocking histamine does what to the blood vessels? It constricts them down, right? And so potentially that can lead to bleeding. If you dry out that tissue enough, it can lead to potential bleeding. Okay, so any questions so far? Yes, ma'am.
For the test, you said you don't want us to know dosages except for Tylenol and not to exceed those.
I think that's a pretty good fact to know. I think that's something that, yeah. Another thing to note as well is like, how do you think you would use Tylenol and ibuprofen together? Like, how do you think you can maximize the benefits of using those two drugs? Yeah, frequently alternate them, right? So a lot of them, both of them can be dosed like every 6 hours, and so frequently you're going to find that you can alternate between the two and give one every 3. So you either give ibuprofen, 3 hours later, give Tylenol, 3 hours later, give ibuprofen, etc. That can be nice because it provides kind of nice around-the-clock coverage. What's interesting, though, is actually in some cases we'll give the two together, and that's okay, too. So, for instance, with our ENT docs, they have literature to support when their kids are getting either like TNAs done, like tonsillectomies and adenoidectomies. When they come in to the hospital for their post-op care, we will actually give them Tylenol, ibuprofen scheduled at the same time, and they find better effects there. They require less opioids. They have better pain scores noted with that. So either way is okay. If the patient's kind of having those periods where towards the end of that 6-hour period they're having pain come back again, maybe every 3-hour alternations is okay. But giving them together, it could be totally fine too. So either way, it could be reasonable. Okay. Any other questions so far? If not, let's do a 10-minute break. We'll come back and then continue on. All right, is everyone ready? We're going to keep going. Now I notice here that no one has been using the sticky board, so I'll either assume that you legitimately have no questions, or you feel so comfortable with me that you can ask questions in front of the group, right? But I highly encourage you, if you have any apprehension or if you have any questions, please post them there, right? It's always a good topic for conversation. And again, if you have a question, chances are what? Someone else has the same exact question and they're too embarrassed to ask as well. So again, I want to make sure no one feels embarrassed by asking questions in my classes. I want to make sure everyone feels comfortable, but that is another outlet if you feel the need to, right? And everyone has the link for that on Canvas, correct? Sure hope so. Maybe that's why no one's using it. Could be the alternative. I think I posted it. I think I've seen questions on there previously. We should be okay. Anywho, so let's get into our corticosteroids, some common ones we're going to run into. Now, we have a lot of nasal corticosteroids. This is good for sort of seasonal rhinitis. This is going to be good as controller medications, meaning typically your steroids are not going to be good for like an as-needed sort of basis here because steroids do take some time to work, right? Does anyone remember the mechanism for our steroids? We've kind of talked about them before, right? Talked about them in ophthalmology a little bit. Where else I'm sure we mentioned them before. So steroids, remember, they work all the way at the very top of the pyramid in terms of inflammation, right? They get down into the nucleus to change how you're transcribing proteins and things like that. So they're very powerful anti-inflammatories, but they take some time to work because they have to affect things like gene transcription, right? So it takes a little bit of time. However, like your antihistamines, though, how long do they take to kick in? Immediate, right? Because they immediately go in, block that histamine that's being released during an allergic reaction. So these are not good agents in this case here for an acute treatment, but they're good for chronic management. So if you have seasonal allergies or you have something where you know you're going to be exposed to an allergen for a long period of time, this is going to be really good controller sort of medications, okay? So you may be like on Benadryl as needed for allergies, but you would be on this one scheduled, or one of these nasal corticosteroids as a scheduled medication. We have a lot of different ones. There's things like beclomethasone, you have budesonide, there's flunicillide, fluticasone, mometasone, and triamcinolone. Kind of notice a little bit of a naming convention there. You can kind of pick out a nasal corticosteroid. Actually, the nice thing about these is they're not just nasal. You'll find when we get to the asthma section that most of these have an inhaled formulation as well that is going to be good for managing inflammation due to asthma. Okay, it's important not to mix these up though. So as an example, fluticasone is a common one that gets mixed up with the inhaled formulation. So there's Flonase, which you would know to use where? The nose, versus Flovent, which is going to be used as an inhaled medication. However, when people are doing MedRec and things like that, say a busy ER nurse is doing the medication reconciliation and they just hear fluticasone, they'll pick the first thing that pops up in the computer and it may not be the right product. So you want to make sure to be aware of that, make sure that you're picking the right product so that we don't give the wrong one to the patient. Anyway, so just don't get those mixed up there. Now, typically what you're going to find is that we're going to use either for allergic or vasomotor rhinitis. They need to be used consistently, and they need to be you need to give it at least a few days to weeks before you really see full efficacy out of these because they are working, again, at the level of the nucleus, right? They're not going to be fast-acting medications here. Now, some things you can find are going to be local sort of steroid effects. The nice thing about using them in the nose is that what do you think you see in terms of systemic effects? Not much at all, which is very beneficial here. However, locally you can see things like epistaxis, you can see septum perforation. Remember, steroids tend to have wound healing effects, right? They tend to slow wound healing, so you can imagine that could lead to something like a septum perforation. Also, that unpleasant taste is due to some of that nasal drainage you can see down the back of the throat there. Otherwise, they're very well tolerated. Not really a ton of side effects you're going to see with these medications, which is very beneficial. Some other ones though, what if we need to use, say, like a systemic corticosteroid? What if your symptoms are so bad that nasal's not going to work, they're more systemic than that? This is where systemic steroids come into play here. And so just a few of them we're going to talk about include things like dexamethasone, which is otherwise known as Decadron. Again, these are synthetic steroids. They're going to be working, again, they're very powerful anti-inflammatories. However, the side effect profile for systemic steroids is going to be pretty significant, okay? Because they're going to be having the same effects as our normal glucocorticoids have in the body, you're going to see a lot of side effects. So things like CHF, hypertension, and fluid retention. Why do we think we see this? A lot of this is due to the mineralocorticoid effects of the steroids. Anyone know what I mean when I say mineralocorticoid? Okay, so when you have steroids, especially like adrenosteroids, things coming from the adrenal gland, there's corticosteroids, like glucocorticoids, and there's going to be mineralocorticoids. Glucocorticoids have main effects on what do you think? Glucose, based off the name, right? So you can see some glucose effects there we're going to see. The mineralocorticoid effects are going to have effects on what? So mineral, think salt, you think sodium, right? So it's going to have a lot to do with water and sodium retention. Anyone know what the main mineralocorticoid that we produce is? Aldosterone is going to be the main one, right? This will be important when we get into talking about hypertension. With the renin-angiotensin-aldosterone system, it's going to be a big player there. So you have your mineralocorticoid effects, you're going to have your glucocorticoid effects. The synthetic ones that we administer, things like Decadron, they may have a bit of a balance between one or the other, right? But they tend to have a little bit of at least both. And so when you look at someone who has CHF or hypertension, you're going to find they tend to hold on to more water because of those aldosterone effects in the kidneys. And we'll talk about what those effects are when we get to hypertension in a couple of lectures here. Also, you can see things like glucose intolerance. So if you have a diabetic patient, you'd expect their glucose to do what? It's going to go up, right? Because again, when you think about like a stress response, normally those steroids are going to cause your liver to start to produce new glucose, unless you're going to see blood sugar levels go up, okay? Just like when you're in PA school, your cortisol levels are high because you're chronically stressed. What do you think your glucose does? It's going to go up, right? Anyway, other things you can see, things like hirsutism, see potassium loss, tendon rupture. You can see that due to the wound healing sort of effects there. We mentioned intraocular pressure increases when we talked about glaucoma, and also it can cause an effect on the immune system to suppress it, right? Basically, it's going to be an anti-inflammatory across the entire system, so it's going to cause immunosuppression, which can increase your risk for what? Bacterial infections, fungal infections potentially, right? Now, when we're doing it for things like allergic rhinitis, right, or for allergies, typically there's going to be short courses that we're administering, right? If you have a patient who's on a long term, this is where you're going to see more of these effects become more predominant, okay? Now, what do your adrenal glands do when you're administering exogenous steroids? They stop production, right? Remember, it's part of those negative feedback loops that you have. So one of the things to also remember is if you're taking steroids for long term, say greater than a week, you're going to find that the adrenal glands will start to shut down production of things like cortisol, okay? So what do you think happens if you were to say stop taking steroids cold turkey once that occurs? It takes a while for the adrenal glands to pick up the pace, and so then you can start to see the opposite effects. You can see hypoglycemia, you can see fluid loss and hypotension, so you undergo this adrenal insufficiency, and you really want to prevent that. So if you're giving steroids for longer, systemic steroids for longer than a week, you have to taper off the dose. If it's just like 5 days worth, you don't have to worry about tapering, okay? So one thing to note with that. I think I'm about to sneeze, so I'm going to okay, warded it off. Anywho, so you're going to find that if it's longer than a week, taper off. If it's less than a week, you don't have to, okay? Less than 5 days. So as an example, has anyone ever seen like a Solumedrol dose pack? Or a methylprednisolone dose pack? That's where it comes in. You have like 6 tablets you're going to take throughout the first day, and then it has 5 the next day, and then 4, and then 3, and then 2, and then 1. That's a self-built-in taper. But again, if you're taking it for short courses, you don't really have to worry about doing that. But that's another way you may see those steroids actually coming in terms of how they're formulated there. So anyway, so dexamethasone is a common one we're going to be using. Again, there's a lot of interactions here that we can see with this, right? So for instance, if you have it on with like say a CYP3A4 inhibitor, like a macrolide, you may see stronger effects out of the steroid there. You're going to find that if you're taking medications for diabetes, they're not going to work as effectively. Why is that? That's causing your sugars to rise, right? So again, it's going to cause these things not to work as well. So just be aware of these kind of interactions and make sure to look these things up. Again, think about the chronic conditions your patient has and how this may play a role, right? And the longer you're taking it and the bigger the dose, the more likely you are to see some of these interactions here, okay? More likely you are to see some of these disease state interactions. And typically, we don't like to use them if we have any kind of like systemic fungal infection, because that's going to worsen your ability to fight off that infection, so you have to be aware of that. And remember, do not discontinue it abruptly if it's been greater than a week, okay? And you could get a secondary infection, it could be viral, bacterial, etc., but that is a risk. Another one we have is prednisone or prednisolone. Prednisone is actually going to be the tablet formulation, and then prednisolone is the liquid formulation. So if you ever have like a child who's receiving steroids, prednisolone is a common one that we'll administer because it already comes as a liquid. Warpred is a brand name for that one. Deltazone is a brand name for the tablet formulations of prednisone. Again, the differences here between steroids is frequently just going to be the duration of action and then the potency of the steroid, right? So how much I'm actually going to have to administer. So as an example, typically dexamethasone is more potent than prednisone. So what do you think it means for the dose of dexamethasone I'd have to give? It's lower because it's more potent, right? So you give smaller doses of dexamethasone. So as an example for like say asthma, if I was treating someone for asthma with a systemic steroid, for dexamethasone I may cap it out at 16 milligrams, 1/6. For prednisone I may have to use up to 60 milligrams, 60, right? So again, just kind of showing you the difference in potency there. Also, the duration of action is different. So for instance, dexamethasone maybe only give once daily, versus prednisone maybe I'll give twice daily, right, potentially. So that's going to be the main differences between steroids. And again, as you work with these drugs, you kind of get a feel for them. You kind of know how the dosing is going to be different when you might use one versus the other. Okay? But same side effects, same activity as you're going to see between this and dexamethasone. So if you know the activity of dexamethasone, you're going to know what prednisone does as well in the body. Okay. Again, nothing different in terms of the contraindications, anything like that. So just be aware that you can kind of lump all those systemic corticosteroids in together. Okay. Next, we have a couple of decongestions, and again, we're going to see steroids come up almost all the time as we come through different disease states. Just know that we're going to be talking about these again. This is kind of just the first introduction here. Now, in terms of decongestants, typically these are going to be directly acting vasoconstrictors, right? We mentioned when you have an allergic reaction, you're having histamine being released. What happens to the blood vessels? Histamine causes what? The dilation to occur, right? That's what causes a lot of the edema and the swelling and all of that. By either blocking histamine, you can cause those to shrink back down, or by using a direct vasoconstrictor, we can cause the same effects here. And this is what these drugs are going to be doing. So for instance, we have oxymetazoline, or Afrin is the brand name. This is a very common nasal decongestant you can administer. Okay, this is going to be just used in the nose, and it will help just specifically with that allergic rhinitis due to that. And so you can see here that one of the interesting things is that when you are chronically administering this medication, though, you tend to find that the receptors are going to respond to that chronic agonist action. So what do you think the receptors are going to do when you have a chronic activation of these receptors? They downregulate or upregulate? They tend to downregulate, right, because they're chronically being activated. These alpha-1 receptors are the ones that are being hit here, right? Alpha receptors what normally activates an alpha receptor? Part of that fight or flight response? Epinephrine, norepinephrine, right? So these are doing very similar actions here. This is oxymetazoline. And in fact, we've already talked about nefazoline. We talked about some of these ophthalmic vasoconstrictors, right? Remember tetrahydrozoline, right? This is the same category, right? Visine, remember we talked about that? Perhaps? Yes, we did talk about it, so you can go back and review that. But these are actually in the same category of drugs here, right? They're all alpha agonists. These are just working specifically in the nose. So, you're going to see that nasal congestion. You're going to see that when you are chronically administering that, the receptors downregulate. So what happens when you take the drug away? There's not as many of those alpha receptors left around. Not as many of them can be activated by epinephrine. So what happens to those vessels? They blow back out, right? They dilate very widely because they can't be activated as well. And so what do you think that does for the patient? Rebound nasal stuffiness, right? It's usually worse nasal stuffiness than what they had from the initial insult in the first place, whatever the allergy was. And so this is why we do not administer this more than 3 to 5 days. Otherwise, people essentially get hooked on it, where they have to keep administering it to prevent their nose from getting so stuffy, right? You can wean a patient off of this if this is what happens, but typically we limit this no more than 3 to 5 days. They call this rhinitis medicamentosa, right? So it's a good board style question, right? Which of these drugs will cause rebound nasal stuffiness, or patients been taking Afrin for too long? What could be a result of that, sequelae of that? These are the things you want to know. Now remember, what did we say about the ophthalmic medications that cause that same effect, that like tetrahydrozoline, the Visines? What did that do when you stopped it after, say, a couple weeks? Rebound hyperemia. So the same effects occur here, just matters of where you're actually administering the drug. Okay, so again, either use it for short courses or you have to titrate down off of it. Ideally, less drug is going to be better overall. Yes, ma'am.
How do you treat the rhinitis medicamentosa? Or do you just wait?
You have to administer the drug and then slowly titrate off. So you basically see how often they're using it, and then you slowly wean them off of that. I had one pharmacist who was working in a retail setting, and he had a big long counter, he'd be working at, and he basically had 3 bottles of Afrin stationed throughout. So as he's working throughout the day, he started to feel it coming back on, he should give himself a squirt, right? So basically he always had his supply available to him. So it can get pretty significant, yeah, for sure.
If someone just used it once a day, would you say to use for more than 5 days?
Probably, but again, the risk is still there, right? So again, it's just that chronic administration is what is seen there. So maybe you can use it for a couple more days before you'd see that, but certainly the risk is still present. Yeah, something to think about. Okay. So again, it can happen with the eyes, it can happen with the nose. It just matters of where you're actually administering the medication. Now, this could also see some systemic absorption, so you do want to be careful in patients with, say, for instance, hypertension, because this can also activate those alpha receptors more systemically. You can see the blood pressure go up. Okay, so be aware of that. If they have like really uncontrolled hypertension, their blood pressure is, say, like 160 over 100, like maybe this isn't a good drug for them. Maybe they should find something else. Like maybe a nasal corticosteroid would be better for chronic use, right? Now, systemically, if you wanted to use something a little bit faster acting or more systemic acting, this is where pseudoephedrine comes into play here. Now, what is pseudoephedrine kind of notorious for? You can use it to make what drug? Methamphetamine, right? So, methamphetamine can be used, or it can be made from the products of pseudoephedrine. So, anyone watch Breaking Bad? Yeah, so they talk about that, talk about going to different pharmacies and picking up a ton of pseudoephedrine. And so because of that perceived risk, the government went ahead and put into place a lot of monitoring and a lot of limitations on how much pseudoephedrine you can get. And in fact, it's not on the counter. It's still considered over the counter, but now it's behind the counter, right? So you have to actually talk to somebody, show them your ID. You can only get so much per month because of that risk for producing methamphetamine, okay? Now, it's kind of a problem because nowadays when you actually go out and you go onto the shelves and you look for Sudafed, frequently there's still stuff on the shelf, but it usually says like Sudafed PE. You know what that stands for? Phenylephrine, yeah, so we'll talk about that in a moment here. It's not going to be nearly as effective as pseudoephedrine, so I always say if you really need pseudoephedrine, just go and talk to the guy at the pharmacy counter or whoever's holding it and actually get the real deal stuff, because this is going to be much more effective than phenylephrine is going to be from an oral standpoint. So this is an oral medication you're going to take here against an alpha agonist, so it's going to cause the same decongestion effects as oxymetazoline did in the nose. It's just going to work more systemic. So again, who might you not want to use this in? Yeah, patient with uncontrolled hypertension, this is not going to be a great drug for them, right? So if they have tachycardia, hypertension, any of those things can be something you want to be weary of using it for those patients. And again, if you have someone who's taking antihypertensives, they're not going to work as well because now you have this drug that's directly opposing the actions there. So that functional antagonism can be a bit of a problem too. So again, if they need to use it maybe for short courses, certainly if it's uncontrolled hypertension, I would avoid this altogether, right? Say it again? Yeah, it can be related to the increase in blood pressure for sure. Mm-hmm.
So if someone has hypertension, and they need a nasal decongestant, you're going to give them Afrin over Sudafed or just non?
So if I had to pick between the two, I would use Afrin over pseudoephedrine. Honestly, I'd just give a nasal steroid, right? Especially if it's not like just an acute sort of issue. If it's going to be more of a chronic, long-standing issue, yeah, certainly a nasal steroid is going to be better overall, right? Now, again, if I were to give a systemic corticosteroid, what's that going to do for that hypertensive patient? It's going to raise their blood pressure too, right? So again, you have to kind of think about the, how they're working, where they're working, etc. Okay. Nasal steroids don't really cause a lot of systemic effects, which is beneficial, although oxymetazoline did cause some, but not nearly as much as pseudoephedrine would. So it's all kind of on a scale, right? So again, phenylephrine, if you ever see that, tell patients it doesn't really work all that well from an oral standpoint. So I always say just go talk to people at the counter and get the good stuff, right? Now, do you ever think something could be a problem in terms of like, say, drug testing? If you have patients taking pseudoephedrine? It actually can. It can actually pop positive for methamphetamine, which is interesting. It depends on how long they're using it, chronicity, and the dose they're receiving, and things like that. But it's something you always warn patients of. Hey, if you're taking pseudoephedrine, just be aware if you have to take a drug test that may show positive. That's okay, because normally if it shows positive, they'll do confirmatory testing. And they'll figure out specifically what it is, and then it won't be that big of an issue. But it could be notable if you're working, say, in an ER and you order a drug test for a patient and it comes back positive for amphetamines. Talk to them and just be like, hey, have you been sick recently? Do you take pseudoephedrine? Things like that. May be able to kind of delineate that.
What's the difference between pseudoephedrine?
Ephedrine we used to use more frequently. So the problem is that ephedrine was a very strong stimulant. You could frequently see risk for stroke, MI, things like that due to the vasoconstrictive effects. And so ephedrine kind of got taken off the market because of that. So pseudoephedrine, not quite as strong. You'd see ephedrine being used a lot for weight loss and things like that, and it's just a lot of people stroking out. It's not a good idea. So ephedrine is essentially removed. They may see ephedra that may be seen in some over-the-counter herbal supplements and things like that. Again, not going to be quite as effective as the actual ephedrine would be. Any other questions? Okay, so mucolytics. What does a mucolytic do? It breaks up the mucus, right? So it's going to be able to lyse that mucus essentially. Guaifenesin is going to be the one mucolytic that we have in this category here, and basically it's a mucolytic and then an expectorant. Expectorant just means what? Cough it up. So when you loosen up all that mucus, you need to get rid of it, so you're going to be able to cough that up a little bit easier there. The big thing to note with this, and again, really not a ton of side effects you're going to see with this medication. However, the one thing I do want to educate patients on, you want to make sure to drink a lot of water along with this. What do you think that is? that water's going to need to hydrate that mucus, right? So again, you can try to break it up, but if it's all kind of like, thick and viscous and all that, it's going to be harder to expectorate. So by giving this with a lot of water, make sure they stay hydrated, it's going to help them to be that much easier to clear that mucus out and kind of clear up that chest congestion, which can be useful for them. Typically, this is another over-the-counter product, so you see a lot of like Mucinex and things like that over the counter. Just be aware, let them know that, hey, you're going to expect to see more drainage because, again, you're breaking up all that mucus, so you expect to see that. And certainly, if their symptoms are not getting any better over time, they probably need to get checked out because there could be something bacterial at play. It could be a pneumonia. Who knows what's going on, right? So that's it for the ENT section. Any questions on that? Yes, ma'am.
You have two different steroids, one affected tendons, the other one affected tendon. Is there something we should know about that?
No, it's just more of a general sort of thing there. So again, the tendon issue can be more of like a healing, right? So you could see tendonitis or a tendon rupture over a long term. Mainly if there's an injury to the tendon, it would have a harder time repairing. Oftentimes you're going to see that, we'll talk about this later on, that steroids can actually worsen osteoporosis or increase the risk for osteoporosis because it actually will inhibit a turnover of the bone. And so that can be a risk for fractures for older patients. So this is just another thing to note there. It's a whole host of side effects with the steroids. So they're pretty nasty drugs, although they're so effective for what they do that sometimes they're just what you need. Yes, sir.
Can these last two drugs be used long-term?
Guanfenicin and pseudoephedrine. I don't see patients that have a requirement to use guanfenicin long term or pseudoephedrine. You're just going to be using for more of an acute sort of issue. You're much safer using guanfenicin long term than you would pseudoephedrine. Pseudoephedrine, I'd probably say if you got something else going on, probably try to isolate that issue there. So if they need something like a nasal corticosteroid, try switching over to that. It's going to be much safer in the long run, especially in terms of hypertension, right? Okay. Yes, ma'am.
Why is it called nausea?
The guanfenicin. So I don't know if you've ever had like a lot of like hawking up like a big loogie or something like that. Like you ever trigger that gag reflex? I don't know. I always find it super gross. Like when I'm trying to cough up something. So again, that could be related to that, especially that increased drainage. Maybe that may trigger that. Some people, a lot of times side effects, how they get listed in a monograph is when they're doing the clinical trials. Anytime anyone has any sort of effect, even if it's due to the drug or not, it gets listed as a side effect. So during the clinical trial, someone probably had some nausea, vomiting, and it's like, okay, we're just going to list it. So that's why every drug can cause nausea, vomiting, diarrhea, right? So it's just one of those kind of ubiquitous things. But at least that's my mechanism I think about it with guanfenicin. So let's switch over. We're going to go to the pulmonology section, at least get that started. I know you're all hoping to get out early. I said, I'm not that nice. And we're behind schedule, so let's just keep going here. So kind of going along the same topics here. So we talked about mucolytic. Now let's look at some antitussives they use along with also for its expectorant action. And when I say antitussive, what does that mean? Yeah, it's going to be suppressing cough, right? So cough's kind of an interesting sort of reflex here. Usually you're going to find that either with stretch receptors or chemoreceptors in the respiratory tract, they may respond to things like chemicals or actual physical irritants. And so you cause this very complex reflex pathway to occur where basically you're going to find that regulated through the medulla, you're going to find that causes this like really deep inspiration, this glottis closure, and then you contract everything together and you get this very forceful expiration, right? So you get very high pressures. They report you can have like up to like 500 miles an hour of like air for a short period of time, which is like crazy, but I've never tested it myself, see how fast I cough. But problem is that you're going to see a lot of complications from chronic cough. So you can see things like insomnia, exhaustion if they're sitting there coughing, not only for themselves, but who else might be affected by that? Yeah, if anyone's sharing the bed with them, they're going to be like, hey, get out of here. Go sleep somewhere else. You're coughing all night long. But certainly you can see things like dysrhythmias can be triggered by this, syncope, rib fractures potentially in some rarer cases. So our goal here when we're treating this is to make sure we're reducing the number and severity of the coughing episodes and hopefully prevent any complications that occur here. This is mainly going to be used for sort of for short-term basis for like, acute illnesses, things like that. Keep in mind you can use opioids for antitussive effects, but that's kind of it's kind of going a little overkill. But back in the day, we used to use things like heroin, for cough suppressants, like back in the old-timey days, right? So we used to do all kinds of crazy stuff. But nowadays, we'll use a little bit more specific medications to try to be a little bit safer. Anyway, so benzonatate or Tessalon pearls are going to be the first one we're going to talk about here. This one's interesting because it actually works as an anesthetic. So it actually blocks the actual signal transmission. When you have something like an irritant affecting those receptors, the signal never gets carried up to the CNS, and so the cough reflex is never actually triggered here. Notice here it comes in these nice little pearls. They call them pearls. You don't want to crush or chew these. The reason that is if you were to say bite down on it and get all that liquid in your mouth, guess what is going to happen? It's going to numb everything up, right? So again, that's why we try to prevent that. Also, if kids get into this, you can actually see more systemic effects. You can actually see things like CNS, respiratory depression associated with this. So this is another one, because again, if you look at this, kids might find that pretty appealing. They want to get into that, right? Also, this is another big one. I'll tell you, from my brief time working in retail, these are one of the most difficult medications to actually dispense, because the second you pour them out, they like to go everywhere, right? So they just kind of roll everywhere. They get all the floor. It's not great. Now again, I'm not going to put them once they're on the floor. I don't put them in the patient's bottle. I just count that as a loss. However, though, imagine people at home, if they're trying to get some of this out and then gets onto the floor and then a little kid gets into it, you can see how pediatric exposure could occur pretty easily here. But anyway, so just note they can cause that oral anesthesia. Due to that, kids may be a little bit more sensitive to that and have some more CNS effects. But don't crush, chew, anything like that, okay? Also, dextromethorphan. This one is going to be over the counter. Tessalon pearls or benzonatate is going to be prescription only. This one's available over the counter. We have dextromethorphan or Robitussin is a common name for that one. Delsum is another one. This one is actually structurally related to codeine. It's actually within the same sort of chemical family. It doesn't cause the same kind of analgesia as an opioid might, but it certainly helps to suppress that medullary cough center. So whereas benzonatate was working directly on those receptors, say, in the respiratory tract, this is working more centrally in the brain to block that reflex, to have the antitussive actions here. So things to note with this one is that you can see some side effects. Some people tend to be a little more sensitive than others to this. But you can see things like confusion and excitement. Some of this is due to some other ancillary actions the drug has, things like glutamate antagonism, things like that aren't directly related to its mechanism for cough, but certainly you can see some issues here. And certainly avoid risking combining with other medications that increase serotonin, because you can see some interactions there. Okay, so if they're on medication for depression, this may be something you may want to use maybe a lower dose, or maybe avoid potentially in those cases there. Okay, now, does anyone know what happens if you, or what they call it when you take a whole bunch of dextromethorphan? Good, you guys are good kids. We're hanging out with the wrong kind of crowd, right? So if you ever hear someone call it robo-tripping, this is what they call it when you end up taking a ton of dextromethorphan, because Robitussin's or robo-tripping. Again, you can find that adolescents who frequently have more time than sense, they will use these over-the-counter medications in order to achieve a high. So we've had patients who will end up taking a ton of dextromethorphan in order to achieve some of these euphoric kind of effects here. It's a very nasty kind of high. You can see things like seizures and dysrhythmias and things like that. So definitely avoid against that. Again, if you have adolescents who may be prone to doing things like that, maybe keep them locked up, things like that. Yes, ma'am.
One time I went to buy a Delsum, I had to, it was on the shelf, but when I went to pay for it, they could come and sign something. Is that wrong?
Yeah, so that's not a legal requirement. That's probably just a store requirement. They probably just said, hey, you probably see these little kids coming by and buying. It's just like, the canned air, like for dusting electronics and stuff, you have to show an ID for that. The same thing is that adolescents are abusing it to get high, and thus they're trying to curtail some of that. Because assuming like once you turn 18, all of a sudden like you're like, oh, I have more sense than that. I'm not going to abuse stuff.
I was 23.
Yeah.
Someone like the Delsum, the PM one, do they have to add
Say-
additional chemicals to that to like try and suppress the excitement, or does it not really affect your sleep?
So it depends on the dosing that you're getting there. So usual typical dosing, you shouldn't really see much effect on sleep. You shouldn't see that excitation. So usually when you get higher doses, or some people just tend to be a little more sensitive to the effects of the drug there. However, if the cough was the thing that was keeping them awake, that being suppressed may be the bigger benefit there in getting them to sleep. Yeah. Sir.
Other than like the history, is there like any way to like know right away if they have serotonin syndrome? Like, is there like any hallmarks for it?
Yeah, so we'll talk more about this in the psych section, I think, next semester here, but there's kind of 4 things you're looking for when you have serotonin syndrome. And again, I'm not going to test on this, it's just because you asked. So they typically have hyperthermia. They typically will have some degree of altered mental status. They will have autonomic instability, which means they can present to like hypertensive, tachycardic, hypotensive, bradycardic, can be kind of a mixture. And they typically have increased muscle rigidity. Typically, this is seen with like clonus, like in the lower limbs. And usually you gotta have to kind of rule out a lot of other stuff where you can say, yes, this is serotonin syndrome, but those are kind of the 4 things we'd be looking for. So, and we'll talk about a lot more about that later on, so don't worry about that too much. Yes, ma'am.
What's the point of having medications like Mucinex DM where you have the dextromethorphan plus the guanine?
Mm-hmm. Right. So sometimes you'll see like Mucinex DM where they're actually mixing the two together. So it sounds kind of counterintuitive, right? Because one's a mucolytic trying to get you to cough up stuff, and then the other one's a cough suppressant, right? So the idea is that by giving the mucolytic, you're going to help to increase or decrease in viscosity, right? So it's going to be able to expectorate it easier, and then any residual cough that may be occurring due to illness could be blunted with the dextromethorphan. So I don't know, no one's actually done a trial that I know of that actually shows the increased efficacy of using the two together. It's just a common thing they combine together, so it may or may not be of any additional benefit to your patients.
Is it possibly because it's not the dextromethorphan, it's not working on the stretch receptors, so it still stimulates you to cough?
Not necessarily. So again, because this is working kind of higher up, right? So even if you did have stimulation of those receptors, the dextromethorphan is still blunting that, right? But yeah, so it's just one of those things where like they have that chest congestion, they kind of feel that junkiness, they can get rid of that, and then any additional cough caused by whatever viral illness they may have can be suppressed by the dextromethorphan. That's my best guess. It's one of those things where I was like, that seems kind of oxymoronic, like giving something to suppress cough and then something to stimulate cough. But again, really the mucolytic is there to try to help to get rid of that, all that kind of buildup. Yeah. Yes, ma'am.
It looks like a lot of these use Zarbee's a lot. Is
Mm-hmm.
it over the counter like for kids? Does it really work?
The Zarbee's, as far as I remember, is a homeopathic product.
Like honey
Yeah, is anyone know homeopathy means or homeopathic? What is it?
What? Like the medicine?
Yeah, like when you say like homeopathic, like what does that mean?
Like the potencies, like how they make medicines, that is different.
Mm-hmm.
Like any medicine which any herb we take, and if you make like allopathic medicine,
Mhm.
that is completely different. Like trituration and
Yep.
that is completely different. And homeopathy, like they don't take everything from that herb. They only take the things which is like important,
Mm-hmm.
like more potentized form.
Mhm.
So that is why like homeopathic medicines are like, even though people are using very frequently, they have much more side effects.
Mm.
Then you don't know how to take those doses because those are like very, very specific, like what do you call?
What, patient specific?
Yeah.
Yeah, so a lot of the homeopathic products you'll end up finding sort of like at various outlets. The big thing there is just the dilution is really the big thing. So you typically find you'll look on the product and they'll say like I'm trying to think. Of Ipecac, like syrup of Ipecac. I know Ipecac comes as like a homeopathic formulation. It'll say like 10x, 1000x, whatever x. That's the dilution they've done. So basically, the product is so diluted that what you're actually getting doesn't even have any active chemical product in it anymore, because it's so dilute. And so it's one of those things where it's like they're practicing like based off the essence of the product. It's supposed to help there. So it's a very minimal causing side effects because there's no product there, right? And so also some people do get some efficacy out of that. Again, there's not a ton of there's not as much clinical evidence behind use of that than other things. It's one of those things where if patients would like to try it, I'm like, go for it. It may be beneficial, maybe not. But as far as I remember, the Zarbee's I think it still falls into that category, but it could be proven wrong if you have a product label or something. Yeah, so again, it's a whole other area of medicine. It's not regulated by the FDA, so that's another important thing to note is that there's not as much oversight in terms of like the manufacturing and things like that. So that is one thing to note. But again, it's one of those things where if a patient wants to try that, it's certainly something you should talk to them about, right? And then you shouldn't just say like, well, homeopathy, that stuff's garbage, whatever. We're not going to do that. Like have a conversation with them because again, a lot of times, even if the product itself doesn't work for them, like mind over matter is a big thing too, right? So if they feel like things might work, then sometimes it does work, right? Yes, ma'am.
I just want to say that even though medications are over the counter, homeopathic medicine, but I would not I did homeopathic medicine like whole course for 5.5 years.
Yeah.
So I would not recommend those medicines to take like over the counter before you consult to any homeopathic.
Exactly.
Because as I say, those gives like really, those are not the side effects just like these allopathic medicines like you take and you have nausea, vomiting or rashes. It gives side effect like a very long time because
it interacts with other medicines
Mhm.
after a long time,
Yep.
not like immediately.
Yeah. So again, that's why I talk to an expert, right? So even if you don't know a ton about it, at least refer out to maybe someone who knows more about it than you do. And there are databases out there, so it depends on what kind of access to resources you have. So again, sort of outside the scope of our talk here, but it's a very good question because patients are going to ask that too. Like, what about this? Is this good for cough or something, and you've never heard of it? Like, you at least need to be able to educate yourself on it and what it is and how it might interact with maybe some of the other things you are prescribing them. So something to think about. Yep. Okay. So anyway, I don't have too much time left. Definitely not enough time to cover all the pulmonary antibiotic stuff. We're getting pneumonias and things like that. Any questions you guys have? Yes, ma'am.
If something's not regulated by the FDA and you encourage use of it and something bad happens, like, isn't that, like, can you get in trouble?
Yeah, so it's a good question. So, if something's not FDA approved, are you allowed to, recommend its use? Yeah, so let's kind of look at a few different cases here. So for one, let's say you have an FDA approved drug, but you're using it for an off-label use. So the FDA says, okay, it's only approved for use for X, Y, and Z disease state. You want to use it for something else, right? Well, you don't want to use it just at random, right? You don't use it for any random disease state. Let's try this and see if it works. No, you typically will have some kind of evidence behind you saying, hey, this is good for that indication. We did a clinical trial and says this is okay. When you have things like that backing you up, you have resources or databases and things like that that show that yes, it is efficacious for that. You're covered, right? So the patient had a bad outcome and some lawyer came up and said, well, why'd you do this? You can say, well, I had this reference that said this was okay, or this is just, this database said this was good, or whatever the case may be. So that is able to cover you. When you're looking at things like homeopathy, there's databases out there, right? There are people who are experts and are more trained in it. So certainly by looking at that, saying like, well, listen, we tried X, Y, and Z, it didn't work for the patient. They were interested in trying this, and so I looked at the references, I looked at the evidence, and said, okay, I think this is reasonable to try. That provides you more cover, right? Than just saying, well, I don't know, just go try it and see what happens. Like, you don't want to say that when the lawyer's coming in and asking you questions, right? So yeah, very good question though. Is like, how do you cover yourself? And frequently, the more evidence you have to back you up, the more safe you are, right? What other questions are there? I don't know. So that's kind of the main ENT home kind of stuff. Yes, sir. Oh, there's questions. Say it again. The quiz. What about the quiz?
I was confirming that there was a quiz.
Oh, I should double check. Is there a quiz next week?
The schedule does say yes.
Let me double check.
Yeah. Is it going to cover the opto?
So let's see. It's a good question. What will it cover? You guys probably want to know that. So quiz 2 looks like it's going to be on 10/11, which is indeed next week. So 5 and 6. So it will cover what we had left over on optho through what we've covered today. So that last bit of optho in the ENT section, maybe a little bit of that dextromethorphan, benzonatate, right? A couple of drugs there. Is that reasonable? That over all the pulm stuff, at least it's over a little bit of that. Okay. So I should probably write that quiz, put it in. Yeah, antibiotics always come up, right? Yeah, it'll be through Canvas. It'll be just like the last one, so it'll be kind of a mixture of different things, maybe some multiple choice, some the matching. I like the matching a little bit. I think that's reasonable. But it should be, huh? Probably not. Those are harder to write because again, you have to come up with every single different. But if you really want one, I can do it. Okay, hold on a sec. Shh. Hold on. Let me answer these questions here. So the question: is it better to take Robitussin that has dextromethorphan versus WO? Oh, then without. Is getting any cough suppressant that is dextromethorphan more effective? What are your thoughts on what is best for this? Yeah, so if it's Robitussin, and again, this is the hard thing with over-the-counter medications, is that they frequently will use the same brand name to encompass a lot of different products. So like when you see NyQuil, you're not always guaranteed to know what specifically it contains. So that's why it's really important when you're talking to patients about their over-the-counter medication use. Have them either take pictures of the bottle so you can see what's in it, or have them see a picture, and that way they can at least see specifically what they're taking. Because people may say Tylenol, but they may leave off the Tylenol PM. Anyone know what's in Tylenol PM? Benadryl, so diphenhydramine plus acetaminophen, right? That's a wholly different picture of what that may look like in terms of patient side effects and things like that than just Tylenol. But people may just say, oh, it's Tylenol. So typically, in terms of antitussive, it has dextromethorphan. That's what it's used for. If Robitussin without the dextromethorphan, I'm not sure what that normally contains. It's probably like an antihistamine or something like that. But certainly for cough, dextromethorphan is probably the most effective over-the-counter product you're going to have access to there. Yeah. What's the difference between glucocorticoids and corticosteroids? They both decrease inflammation. What really separates them? The corticosteroid is kind of the overarching categorization. When you break them up, you have the glucocorticoids and the mineralocorticoids. They kind of fall underneath that category there, right? In terms of their activity. So when I say dexamethasone, sorry, I get my dextrose mixed up. When you have dexamethasone, that is a corticosteroid that has both mineralocorticoid and glucocorticoid actions. Okay. It's a little bit stronger glucocorticoid action, so sometimes I'll use that nomenclature, but that's really the difference there. And then, is it okay to use Afrin for epistaxis if it is in the kissel box area for 3 days to see if it helps stop bleeding? That I would have to look up specifically, but they do use Afrin for nosebleeds. I'd have to double check if they need it for longer than that. Usually, if it's longer than that, I'd imagine you probably need to see an ENT doc to get that fixed. That sounds not great. You're still bleeding. So, any other questions? If nothing else, I will see you next week, and we'll have our quiz. Oh, yes, ma'am.
I think I missed it. Are you going to have Robertson and Delson on the quiz next week?
Yeah, that'll be on because we talked about it today. So, all right. The first couple slides for Palm will be on the quiz potentially.